I wanted to talk about shared decision making. I kind of thought this is one of these touchy-feely kind of things, but the fact of the matter is that when you start reading about this, the people who are into it basically think that this is a moral obligation that we have to let people share in the decisions related to their care. And I think one of the things that will help you decide whether this is important or not is it always works in the emergency department is to say, well, what would I want for my family? And if you say that, and you always get the right answer kind of thing. In this case is, yeah, I think that they should have some say about what's going to happen to them. And to do that, you have to give them information about these decisions. It's even noted in here that CMS will not pay you for certain procedures unless you've documented in your record a shared decision-making conversation. And the three of those are implantable cardiac defibrillator. They also had, what else? The left atrial appendage closure for AFib and lung cancer screening by having a CT for smokers. And that all of them require shared decision-making discussion documented in the record. For emergency medicine, there's a guy by the name of Lauren Yamamoto. He's an ER doc, pediatrician in Hawaii, and he came up with two studies way back in 1997. And he basically had febrile, he's a pediatrician kind of guy. He had kids between the ages of 3 and 36 months, and the issue was, do you do a workup for bacteremia, occult bacteremia? This is in the era where we were looking for occult bacteremia. We're much less interested in that now, but during that time, kids who had source unknown fevers in that age were thought to have pneumococcal bacteria circulating around, and maybe if they did, it was going to settle in the brain, the lungs, those kinds of things. So the idea was to identify occult bacteremia. And so the question he posed to parents are occult bacteremia is a possibility. Here's the likelihood. Statistically, it might be 3 in 100 or something like that. Now, given that, do you want your child to have these tests? Do you want them to have urine culture, blood culture, chest X-ray, and a spinal tap? And the parents vociferously said, we don't want any of that stuff. Let's just see how Johnny does, and we'll go from there. And so their value system said, we would rather not do these tests now, and we would rather hold off and see how the child does, which seems like a perfectly reasonable decision once you say the likelihood of occult bacteremia is like 2 in 100 or something to that effect. The other study that is still in 1997, that kids had a laceration, and they asked the parents, listen, we can numb this up with a needle injecting lidocaine around this wound, or we've got this thing called TAC. I don't know if you remember when there were people who were talking about tetracaine, adrenaline, cocaine, and you put it on a cotton pledget and would put it on the chin for Mary's laceration, and it would numb up the chin without having to stick the kid. So the intuition is, well, obviously they're going to choose the topical anesthetic. They didn't. Overwhelmingly, they chose to have Mary shot up with the local anesthetic. So you would not intuit that, but for some reason that was the choice of the parents. So basically, you could have said, listen, we have a couple of ways to do this. We can put this thing on here, or we can give the shots for the Novocaine. What the reason was for the choosing that really is unclear. One of the other things about shared decision-making is people say, it's going to take too much time. I don't have a lot of time to do this. All the studies that looked at how much time this takes, generally 2-3 minutes. I'll show you the 1.5 minute kind of thing. It's really quite nominal in terms of the time it takes to involve people in this, rather than saying, okay, we're going to do a CAT scan of your kid's head. So that's studies 1 and 2. Moving on, though, low-risk chest pain. Low-risk chest pain now has really evolved. The American Heart Association used to say, okay, low-risk chest pain, they can go out, but they have to have some kind of a stress test or something like that within, I think it was 72 hours, or was it 48 hours? Basically, if you're going to let them go, they had to get checked real quickly with regards to a stress test or some other kind of screening test like that. Now, basically, they said the workup's done, and the likelihood of this person having a problem in the next 30 or 45 days, when they call this MACE, these nasty things that can happen, major adverse cardiovascular event. Anyway, now the Heart Association has really backed off, and on the guidelines that we were talking about here in the course, it's really remarkable because the Heart Association used to kind of waffle about may consider those kinds of things. Now they're very black and white. These people can go home if they have met the lowest criteria for the heart score or something akin to that, and you've done the heart pathway, and the two troponins are negative, the EKG is negative, those kinds of things. That person could go home. Or if they felt uncomfortable about going home, the decision would be, well, we can put you in the observation department for a few hours or a half a day or until next morning and see how you feel and see how you do if you're concerned about going home. So that most people will say, get me out of here. So that's 3 and 4. And one of the things that people are using now is these, what do they call these little things? You see this picture here where they visually show you the odds of you having a problem based on, and they discuss these kinds of things so that you are fully informed and you're consistently shown the chart, 3 out of 100, if that was the case. This is just an example, and they give all of the opportunities to discuss the risk, benefits, and the like of going home. And in this thing for low-risk chest pain, they always have this kind of like this dry run kind of thing where they have a few people involved in to see whether this thing works or not. And then after they think that it works, then they take it out to a broader category. Here they had 913 people involved in this low-risk chest pain decision study. Took 1.3 minutes on average to talk to people about this chart and the decisions involved. And when people are involved in making the decisions, they're much more likely to want to go home. In the pilot study, admission was significantly reduced in the small study that the pilot, and then the study of 900 and some people, admissions were reduced by 15% based on the fact that this is what the patient said they'd like to do. Some of them stayed, some of them went, but you can envision the patients preferred, amount of money that is saved in the process, and you're pretty much kind of covered. If you go through the heart pathway and you follow it, and you risk stratify these patients and follow it, it's kind of basically said, I did what we could, I followed the path. Is it 100% perfect? No, but that means that if you want to be 100% perfect, every person with chest pain has to be admitted to the hospital. So you can't really do that. And when we're talking about, we're talking about likelihood of problems happening in like 3 or 4 per 1,000 people. Yes, is there some people are going to have a problem? Yes. But some people are going to have a problem just by coming into the hospital, and we'll screw them up some way. So there's this coming into the hospital is not without risk. So that's abstract number 3 and 4. One of the things they talk about is the framework for making a shared decision process, and they basically say you have to have 3 things. You have to have lack of uncertainty. You have to have a lack of uncertainty. The options are pretty much even. And if they're not pretty much even, then it's kind of like you basically need to tell the person, this is the safer thing to do. This is the risk benefits are here, rather than. But when they're even, Johnny, you want Johnny to have a tack on it, or do you want Johnny to have the shots, which is pretty much even? Then, when it's even, then you can involve the patients in the decision making. The other thing you have to do is determine whether they have the ability to make a decision. That's called their capacity. Competence is what is done by a court. They decide whether you're competent. But capacity, you decide whether a person's got capacity by saying, the conversation seems normal. They seem to be in a position to make decisions. They know where they are. There's no evidence of any kind of compromise in their thought process. So that's number two. And you need to have the time, and that's kind of listed here as one of the three factors. But every time you look at the time is 3 minutes or less. Here was 1.4 minutes. So it doesn't. That's doable in the emergency room. Please don't say, I don't have time to talk to them about why we're not going to take an elbow x-ray of Mary because you grabbed her and now she's holding her arm and won't move it, and we don't think we needed to an elbow x-ray, even though you do. Here's the risk and benefit of doing an elbow x-ray. Here's the risk and benefit of not doing an elbow x-ray in this setting. They also go through, at the bottom of this, is some of the highlights regarding what is shared decision-making, what it is. It's acknowledgement of a dilemma, sharing information, exploring the values of the decision-maker, the patients, and mutually deciding. So it's you both have input into this decision-making process. You're giving the information to make it clear they're pretty much even choices. Misperceptions, they say, it's just informed consent. No, it isn't. Informed consent is basically, Mr. Jones, we would like to take out your appendix. We have appendicitis. If we don't take out your appendicitis, here are the risk and benefit of taking out your appendicitis. You may get an infection for the appendicitis, but then again, you'll never have to worry about it coming again. So that's number one. If you decline to have your appendix out, another option is we can give you antibiotics. And it's been shown that antibiotics will help a lot of people, but you should know that down the road a bit, there's an increased likelihood you'll have to have your appendix out then. So that's first choice, second choice. Third choice is, what if you do nothing? If we do nothing, the risk and benefits of doing nothing are listed. So here's what we want to do. Here's an option if you don't want to do that, and here's an option if we do nothing. That basically is informed decision making. It's 9 processes. Here's what we want to do, pro, con. If you don't want to do that, here's what we want to do, pro, con. If you don't want to do that, we'll do nothing, pro, con. So that it's just not, we're going to like to take out your appendix and there's a risk of infection and we want you to know that kind of thing. That is kind of what is generally done, but theoretically, you have to give patients other options. If you don't want to do number one, here's your choices. So misconceptions, it is just informed consent. No, it really isn't. It's just good communication. No, it really isn't. You can only do this conversation when you are talking about two things that are more or less equal. Talk about that here, equipoise. Never. That word kind of is not one of my favorites. The goal is to decrease resource utilization. No, that's not really the goal. I mean, it tends to result in decreased utilization of resources, but the idea is it's using the values of the patient in terms of what risks they're willing to take. Let me take Johnny home. I don't think we need all those blood tests. I'll bring him back if he's not doing any better. Sounds like it's not unreasonable. After the physician has examined the child and basically said, this kid looks okay to me, Mom. Shifting responsibility. Well, it does shift the responsibility a little bit in terms of, well, we decided on this together. I gave the patient the options, and this is what the patient chose. And I think that those are the major misconceptions about it. But in emergency medicine, there are absolutely a huge number of options when shared decision-making could come into play. Much more, I think, than you think about, well, we'll talk about some of the, ones that are more traditionally viewed. Shared decision making for syncope. So in this case, they stratified the risk of syncope using the Canadian syncope score, and basically these people were considered to be very, very low risk. They said, you are low risk, you're not at no risk, but you're low risk. Here are the options. We've worked you up, we've done an EKG, we've monitored your rhythm. We don't see any evidence of anything that we can see that caused that syncopal spell. You didn't have a sudden loss of consciousness like that, which is more typical of cardiac syncope. So we think that as best as we can determine, it doesn't seem to be anything serious. And the same thing again. There's this same guy. This time they got 3 at the bottom out of 100, so they get to visualize what these risks really are. There's the explanation of the risks so that the patient. I gave the patient this. They understood this. In some cases, you could just have them sign that I got it and I understand it, kind of thing. Put that in the chart as part of the business of showing that you did a decent job here. They talk about the phraseology that you may use in this. Mr. So-and-so, we have a decision to make here. There are a few options moving forward, and we'll give you some examples of those a little bit later. With regards to exploring values, preferences, and how you're feeling, what do you think about, what are you thinking after you heard the options? Do you have any practical concerns? Can you come back easily if there's some problems developing, or do you have access to a car, et cetera, et cetera? What matters to you most? They'll say, going home and feeding the cat. That matters to me most. I don't know where you get these charts, to tell you the truth, but it would be nice to have them on a whole variety of things that we deal with, especially the things that are a little bit more serious, like syncope, low-risk chest pain, those kinds of things. So all of them are using data. Like, here's the charts. Here's the risks. We're adding up the risk. You're low risk. I'll show you right here. You're considered very low risk. This is the same thing where they did a little feasibility study with 50 patients. And in this setting, it's only 50 patients. Shared decision making, 17% wanted to be admitted to observation after their syncopal spell, after they were given shared decision making. 27% wanted to be admitted for the observation when there was no shared decision making. So here's another example of decreased desire by the patients to come into the hospital. You basically said, you're low risk. If you really feel uncomfortable, we'll put you in observation for a while. Now, in that study, they said the 17% and 27% were not statistically different. Well, it looks like they're different. 17 and 27, they're not different. Here's the problem with really small studies like that. When you have 50 patients, the mathematically 17 and 27 become statistically equivalent. If this study had 1,000 patients and half the patients had shared decision making and the other half didn't, and the differences were 17 and 27%, you can be assured that the differences would be statistically significant. So in small studies, you need huge differences to show that they're statistically significant. Huge differences. When you have big studies, and like Ken even mentioned, overpowered studies, you got 6,000 people in the study, small differences will be shown to be statistically different, but they may be clinically irrelevant as small differences. So this study was too small to show that 17 and 27% were different. 7 is about using the new American Heart Association, these guidelines, which basically, it seems like if you follow them, it's a recipe that says, I followed the American Heart Association, which is generally viewed as a credible organization. I followed their pathway. I did everything they said, and there was a bad outcome, but here's my record. I did everything that they they recommended, and 1 in 1,000, I had bad luck. My patient had bad luck. So this is also, they list all of the low-risk criteria for the patients. Heart score being one of them is the most common one now. And they're listing all of these 2021 guidelines. And this is what we went over in this section here about these new guidelines, which are pretty revolutionary in terms of they're not wishy-washy. They're saying, do this and you'll be okay. Next one, number 8, is antibiotics for URIs. And in this one, they give primary care doctors a kind of like a little schooling into the value of antibiotics in 4 disorders: sinusitis, bronchitis, pharyngitis, and otitis media. So their decision-making thing was not just this one little chart with 3 guys at the bottom and 100 pictures. This is four disorders and the value or non-value of antibiotics in this setting. Half the doctors were told, here's the data regarding antibiotics in these 4 conditions. Another half were not. They talked about shared decision-making, where you want to take the antibiotics, I can give you a prescription for antibiotics, and if Johnny's not getting better, you can start him on the antibiotics, those kinds of things. The vast majority of people who get antibiotics are not going to be helped by these viral illnesses. You have to worry about side effects, rashes, diarrhea, those kinds of things, C. diff. And when physicians talk to patients about these primarily viral illnesses, only 27% of the physicians wound up writing prescriptions for antibiotics. In standard care, no shared decision-making, the antibiotics were 52%. Twice as much was when patients were not involved in the shared decision-making process. Like, well, we don't need to give, I'll hold off on the antibiotics because I don't want these nasty things to happen. And if Mary's not doing better, I'll either come back or we'll fill a prescription for the ear infection that you gave me, since we know that, all of these are going to generate very little in terms of improvement in terms of outcome. Yes, will you get, half a day? Maybe. And the numbers for that are listed there in the, but the bottom line is antibiotics, 27% versus 52%. The fact of the matter is 27% is still high. Maybe it should have really ideally be like 5 or 10%, but that wasn't the case. We did a heck of a lot better when people were given the information, given the numbers. Patients were able to make a part of the decision here. Also, patients feel like they know more about what the disorders are that they're having because you've had this 1.4-minute discussion with them regarding it. So there's some good things that happens. But number 9 is really, there's the next 3 papers basically say if you do shared decision-making with patients, the likelihood of them being annoyed with you when their outcome is kind of negative and talking to a lawyer, at least theoretically, is a little reduced. Although, to be fair, the most common reason for malpractice suits is malpractice. Lawyers don't want to take cases that are kind of iffy. They want to take care of cases where they're going to win clearly. So when they talk about number 9, this is kind of interesting. This is somebody where they missed a diagnosis of appendicitis. But in this discussion with the patient before they discharged the patient, and the patient came back with appendicitis, ruptured, that kind of thing. In the discussion that the patients and the doctor had together, the doctor did some brief shared decision making. Some brief. That was one group of people, and there was an internet survey. 804 people were asked, "How would you respond if this appendicitis case was missed, member of your family kind of thing?" And the doctor had this discussion about the risks of associated going home. We're not guaranteeing you don't have it, but we don't need to do anything further at this time. So a small amount of shared decision making. Then there was another group had full shared decision making. A lot of conversation about appendicitis, risk benefit of going home, etc. Why we did or did not do a CAT scan. And then there's another group that got no shared decision making. So there's a little bit, a lot, and none. in the setting of a missed appendicitis case. And then the question was, what was your likelihood of, talking to an attorney? If you had a little bit of shared decision making, it was 12%. If you had a lot of shared decision making about this one case, this appendicitis case, 11% was say they'd go to an attorney. How many people would go to an attorney if they had no shared decision making? 41%. 12, 11, 41%. So it tripled, at least tripled, maybe 4 times the amount, because the patients were involved in the decision-making process. They did their best. They talked to the patient about this, that, and the other option. The patient decided, I feel comfortable going home. And this was one of the 3 papers. The next paper is similar. It's kind of like, what is the next one on? This is PSA testing. PSA testing. But they also, in this one, is basically a Danish study online, again, another online survey about PSA testing. The diagnosis of cancer develops because PSA testing wasn't done, but the patient agreed not to have it done because they were 75 years old and basically were told it wasn't going to help you anyway. And so they had these vignettes, and in the vignette of poor outcomes, shared decision-making was associated with the lowest rate of legal action taken by these 800 people who answered this internet survey. And then they have a mock trial with regarding VBAC, vaginal birth after cesarean section. And they had these jurors, and the jurors were supposed to determine whether the standard of care was followed. And there was patients who there was no documentation in the record of any kind of shared decision-making, an informed kind of consent kind of thing. In that case, 20% of the jurors said the doctor followed the standard of care. Basically, no discussion noted in the chart. When there was documentation of a discussion, 70% of the jurors thought the doctor had followed the standard of care. When there's decision aid, the decision aid being that chart with the 3 people in the bottom and all the 100 people there, when that decision aid was used, or something similar to that was used, in the setting of shared decision making, 98% of the people thought that of the jurors thought that the doctor followed the standard of care. You can envision how strong your chart would be if you could put it into the chart. Here's the chart. I showed the 3 people. I showed all of this stuff because it was done in advance. So these are called decision aids. It'd be great if there was a book of decision aids to help you with, depending on the specialty that you are. 12 talks about the transition between informed consent and shared decision making, where shared decision making is kind of in one column there, showing that there really is a difference between informed consent and shared decision making. One of the issues here that talks about, as an example, prostate. So there was this young resident who had shared decision-making with his patient about getting a PSA or not getting a PSA. And in this case, based on the discussion that they had, the patient decided not to get a PSA. Patient develops prostate cancer, has a bad outcome. Patient sues the resident who had the conversation with him about not getting, and they didn't do the PSA, sues the resident. Resident said, I did the shared decision, I gave him the information, and there was a risk, it's very small. Patient agreed to take it, and this is what happened. The resident lost the case. The resident lost the case. Why? Because in that community, it was not the standard of care to give patients the option to choose or not to choose having their prostate PSA. In that community, they said, okay, it's time for your PSA test. And there was no discussion about why you should or should not get a PSA. They said, and so what they said here is that in this setting, the community standard was not to talk about the values of talking shared decision-making regarding prostate. And so this doctor, this young resident, did not follow the community standard, which is not to involve people in the discussion of prostate, and he lost the case, which is kind of weird, because I kind of thought that there was not really a local standard now. There's a national standard about these kinds of things. There's the journals, the internet, all of this stuff. So, what you do in your community, if it's fundamentally wrong, just because it's the standard of care in your community, that still shouldn't matter. But apparently it did in this case. So our time is up. There's a whole bunch of opportunities to talk about shared decision making in emergency medicine at the back of this. Johnny bumped his head. Are we going to do a CAT scan of the head or not? Here's the pros of doing it. Well, we'll pick up any kind of lesion in his head. The cons of doing it is we're going to radiate his little brain, and he's going to not have to go to college anymore, kind of thing. So 50-50, there's a lot of them in emergency medicine that we could kind of engage patients with. They like they like it. There may be some suggestion that they will complain less. You don't even want them to complain to the hospital. Because once the CEO or COO hears that there's a complaint in the emergency department, that's the last thing they don't want to hear anything about what's going on in the emergency department, no less complaints about the care rendered by patients. So that may be, it doesn't involve a lawsuit. It's just basically a complaint about your care that went to your CEO. You don't want to have that.